मोहब्बत से उनके पास 70 नौजवान
It shouldn't come up. Or if you want to just type in there too. And you can ask if people can hear you.
Hello, can you hear me?
We can hear you, Dr. Man, online.
Okay, good afternoon, everyone, and welcome to this IMT teaching. My name is Abdulrahman Kolapo. I'm one of the registrars. Today it's a bit interesting. The good news is that we've got Dr. Jonathan Mann here as well. We'll be doing this talk together. So it's a big topic that they want us to cram into a short period of time, but we'll do our best. And the consultant here hopefully will get the very best of tricks and tips. Today we will be covering certain things, including a general overview of ischemic heart diseases and myocardial infarctions. We'll be talking about the acute coronary syndromes and patient presenting with stable angina. Would also make mention of acute aortic syndromes, especially aortic dissections. We'll be making mention of the guidelines as we move along, and we will talk about the kind of investigations as well as the various forms of stress tests. Again, as we move along this talk, you will be able to identify times when you need to make quick referrals to the specialist. So I've just put in here definitions which, which are terms that, essentially overlaps at some point. Coronary artery disease, ischemic heart disease, acute coronary syndrome, myocardial infarction. It's good to be clear in your mind what you're trying to refer to when you use these terminologies. Essentially, coronary artery disease means that you've got disease of the blood vessels supplying the heart. And it includes ischemic heart disease, which simply means that this disease of the coronary vessels are causing reduction in blood supply to the heart muscles. So you've got ischemia. And we do know that if ischemia persists or it becomes quite significant, that could then cause what? Infarction. So infarction is cell death and ischemia is reduced blood supply. We also talk about acute coronary syndrome, which simply means an acute event has happened, which I would elucidate as we go on, because it's a whole big topic on its own. A myocardial infarction means you now have cell death, and there will be some evidence of troponin leak in the blood. We'll clarify that as we move along. So a bit of epidemiology. The leading cause of death globally remains cardiovascular disease, and on top of the cardiovascular disease list is coronary artery disease. In fact, it's also the leading cause of death in the UK. About 2.3 million people live with this condition as it is. I got this data from the BHF, and they've gathered a lot of data, and they now know that about 68,000 deaths occur yearly, approximately this, which is 190 per day. It doesn't just kill old people, it's also the biggest killer of younger people. So it causes a lot of premature death, people less than 75. 1 in 8 men will die of coronary artery disease as it stands today, and 1 in 14 women. And this is much better than the data we used to have, where it kills much more people. Almost all heart attacks back then, almost all MIs result in death. It's also a huge cost to the system, about 100,000 admissions of myocardial infarction each year. And I'm sure all of you will be able to tell by the number of cases you see in A&E coming with chest pain, MI. We're always sending troponins and this and that, okay? You can also tell by how how busy the cardiology system is within the hospital. There's a small graph here that's just showing the leading cause of death, and this is from 2002, and you can see apart from Alzheimer's, which is slightly above coronary artery disease. Coronary artery disease takes a huge chunk. If we remember, Alzheimer's dementia is more of a disease of the elderly. You see this more in people that are more or less older than 80. Okay. So the next thing I'll talk about is a quick pathogenesis or pathophysiology of why do people get ischemic heart disease in the first place. The main problem here is atherosclerosis. And if we look at most babies, this is a process that starts as early as, in fact, some people say in utero. And most children at the age of 3 would have had some form of atherosclerotic plaque. You can see it starting to build up. However, there are a number of risk factors and things that will predispose to progression of this, in fact, that could also accelerate atherosclerosis. Some of these are modifiable and some of these are not. You can't do anything about age. As you grow old, it means that this plaque continues to build up. Male gender, family history. Smoking is also a big risk factor, and those are modifiable ones. High blood pressure, cholesterol, people that are sedentary or obesity, those are some risk factors. Socioeconomic status, a poor socioeconomic, or people from low socioeconomic status or situations tend to have higher incidence of coronary artery disease. They also tend to have higher morbidity and mortality. The northeast of England and some part of Scotland have been shown to have the highest mortality from coronary artery disease. Okay, and lack of social support as well. This picture is just showing you some of the examples of the risk factors. Okay, I'm now going to move on to the pathogenesis. This is a common question back in medical school, and I think it's good to have this at the back of your mind. It also helps you understand what's going on. So it always starts with endothelial dysfunction, or what I like to call endothelial injury. Something causes a nick in the wall, in the endothelial lining of the blood vessels, could be due to the turbulent flow of the blood in hypertension or cigarette smoking or conditions like diabetes. Once that happens, when there's a nick in the wall of the blood vessels, you then have all this cholesterol, which are in the blood, especially LDL cholesterol, leaking into the damaged blood vessels, and then they get trapped there. That's not their normal residence, and so they spook the immune system. What then happens is that the immune system reacts. This LDL cholesterol becomes oxidized. We've got monocytes migrating into the walls. Obviously, more monocytes grow up, they become macrophages and engulf this LDL, and then they become a cluster of what we call foam cells. Obviously, this is this then triggers, or there's some cytokine sent to trigger the smooth muscle cells on the wall of the vessel to sort of start to grow, and they push out into the lumen of the vessel, causing narrowing, and you start to have, that whole complex is called a plaque. So the smooth muscle form a fibrous cap on top of this atherosclerotic plaque. Now, the thicker the plaque, the more stable the atherosclerosis plaque. Okay, so the problem here is that some of these plaques are not stable, especially in people who have a lot of this risk factor, and there is a risk of rupture. If they do rupture, that exposes the whole content of the atherosclerosis, which triggers platelet aggregation, and then can quickly occlude the blood vessels. And then we have acute coronary syndrome in that case, which we'll discuss further down the line. This is just an explanation of what we've just talked about. And this is just a picture showing sort of how the whole thing narrows, and at the end there you can see a rupture occlusion. Okay. So do you want to?
Thanks very much. I'll just share my screen. Can you all hear me?
Laptop. Okay, can you share your screen?
So we need to change to laptop. Yeah.
Yes, keep going. Dim it more. I have an app. Yes.
That was loose, wasn't it, before?
Oh yeah.
Here we go. Right. So let's, I think what I'll do is I'll minimize that and we'll come to here. Yeah, so sorry for the mammoth title, and this is just to show the working out and how things are. So let me just change my slideshow. I'll just go to use presenter view, transitions. I'll advance it on manual click and not on mouse click. Okay, now we'll share this. Okay, so very long title, just half of cardiology, so sorry about this. And obviously you get two for the price of one, rather than hopefully not one for the price of many. So again, welcome, so I won't repeat too much. And we're supposed to base this on this masterclass book, which is from 6 years ago, so it's out of date. and obviously you're going to be registrars at MRCP, and we assume that you've got your ALS provider status all sorted, which is prerequisites. And let me know if there's any sort of GP trainees here or anyone doing GP VCS or not on the IMT scheme. And so that means you've done your ALS, and obviously the ALS manual has got a whole load of stuff on acute coronary syndrome, MI, cardiac arrest, VF, etc. And you can buy that masterclass book on Amazon for 40 quid. And this tells, and it's actually quite useful. So this is a sample that I don't want to breach the copyright infringement things, but cardiac arrest and a whole load of sort of general talk to the patient, look after them, holistic care stuff, and be careful to keep communication and be compassionate and sort of overall caring, which is what we all want to do. So this is sort of how to do this talk. And I'll just skip through all this because I think you know all this stuff. And then I've basically lifted the out-of-date NICE guidelines. So we can't stick to what we were told to do, go to the national guidelines. So you go to NICE website, acute coronary syndrome, stable angina, and then the European Society of Cardiology have sort of changed stable angina to chronic coronary syndromes instead. So why use 2 words when 3 will do with more syllables and make it sound more complex? So the NICE guidelines, which are out of date, we'll go through them anyway. So STEMI, ST elevation on your ECGs, you know this, and in this day and age, we've got the paramedics, we've got the people at home, we've got the ads on TV, and we've got the ACPs. And so on an acute general medical take, you're not going to see much of this, and they even bypass their nearest hospital. So if you have a STEMI in Skegness, then you'll get driven past Pilgrim Hospital, go straight to the Lincoln Cath Lab, and have a primary PCI. And then also there's some people who are not suitable for primary PCI, and then you do thrombolysis, fibrinolysis, or do you use medical management because it's not worth it. It's all very controversial, and thankfully we've got our parallels with the current stroke management, and they're basically doing what we did in cardiology now, what we did sort of 25 years ago, and how we developed the primary PCI pathways about 15 years ago. So basically ST elevation, get to the nearest cath lab, open up the blocked coronary artery, and if you can't do a primary PCI, do thrombolysis. It's relevant now in the sort of under the winter pressures, because only a few days ago a STEMI patient was thrombolized, and also because we've got our cath lab here at Lincoln being fixed and serviced and not working very well, we've got low capacity, and we've had patients diverted to Nottingham for their primary PCI. So an extra long journey. When we first started here, we actually had some people helicoptered in with this, the air ambulance, even from neighbouring regions, so from Peterborough, from Hull, from Yorkshire to our, because we were sort of very friendly on a helipad just out by the renal units. So essentially, you work through the primary PCI, that you give your antiplatelet agents. So you give aspirin 300, as you know. You get your second antiplatelet agents. You choose. You're supposed to choose between prasugrel, ticagrelor, and clopidogrel. But we now have in our guidelines give prasugrel for primary PCIs, give ticagrelor for NSTEMIs, and give clopidogrel. There's a high bleeding risk. And again, all these funny abbreviations. HBR, high bleeding risk. That's what. You read all these guidelines. It's nearly 200 pages of this stuff, and there's more than 100 slides, 110 slides to work through. I'm not going to show you all of them, thankfully. But HBR stands for high bleeding risk, and basically clopidogrel when you haven't got enough money in your trust, or you want to not cause much bleeding. And prasugrel 60 and 10, so 60 loading, 10 maintenance, and you can adjust for renal function, weight, and bleeding risk. And then you just open up the blocked coronary artery, and I'll show you some videos of how we do angiograms, angioplasty, stent insertion a bit later, just to keep you and me awake. And then the thrombolysis, so we thrombolized somebody the other day, and we're sort of reliving this in stroke. So So apparently we're using alteplase and not tenexaplase in this unit while we get the cath lab fixed. And then obviously back in the day, when I qualified, we used streptokinase 1.5 million units. We used to give heparin infusions, measure the APT, APTR all the time. Then we've developed some enoxaparin, and as you all know, we give fondaparinux for ACS nowadays. And when they go to the cath lab, they get lots of blood thinners, so they get lots of heparin, and the procedures, all the equipment doesn't block off. You don't cause any more clots in the coronaries. And I always tell the doctors joining us in cardiology that in cardiology we're obsessed with the things that we're normally not obsessed with in general medicine. So we quite like to know the heart rate, the blood pressure, the renal function, the hemoglobin, the platelets, and whether there's anything that stops us from doing things. So we don't want to thin the blood, make people bleed. We don't want to damage the kidney function. We don't want multi-organ failure, cardiogenic shock, and critical care, and cardiac arrest and death. So that sort of summarizes this sort of out of date, sort of nice guidelines from 6 years ago. That's the STEMI. For NSTEMI, like I said, we prefer to give ticagrelor, maybe clopidogrel, and not prasugrel, because prasugrel is a lot more bleedy. And then the important thing at the second box, we should measure the GRACE score in pretty much everyone. So just like you've got your smartphones for measuring sort of the curve scores, all these funny risks scores, and you measure the GRACE score, add in the pain, the risk factors, the BP, the pulse, ST elevation, heart failure or not, and suddenly you get a GRACE score in a number of points. But that translates to the risk of death in 6 months. And so you've got a grade of a spectrum of death rates per GRACE score. And essentially, if the GRACE score is more than 3% risk of death in 6 months, then you may want to keep the patient in and do an angiogram. And if the angiogram shows a narrow blocked artery that's caused an infarct or about to cause an infarct, then you balloon it and stent it. So 3% is your sort of cut off for keeping people in. And then I won't go through in detail the stuff on the right hand side, which is all this is getting out of date. It's time for some new nice guidelines. And never forget what you do after you treat the patient. So you treat their risk factors, you give them the correct medical treatment, the secondary prevention, and optimize their cardiovascular risk. And I won't do the sort of go around everyone and ask and interrogate you for what the risk factors are. We all know it's sort of age, men get it before women, smoking, diabetes, hyperlipidemia, concurrent cardiovascular disease, etc. And also there's sort of new things that are coming out like lipoprotein(a) as part of your lipid sort of profile, which we previously couldn't treat before. And we sort of work with all of those things. And just like stroke units and having a coronary care unit, just by having those things in place, make the patients do better, because somehow you sort of squeeze more information, education, and rehabilitation, and the patient will get used to being their own sort of expert patients, sort of knowledge, and do better for that. So there's lots of studies that say even if you have a CCU, you do better than when you admit to a general medical ward, and when you have cardiac rehab, you do better. And sadly, we've had when I came here in 2010, the cardiac rehab service for inpatients got pushed out into the community. The smoking cessation service only 2 years later got stopped, and thankfully we now see the smoking cessation team back in use in the hospital, and they're very handy and they know quite a lot. And then again, I just my headline sort of take-home message there is that we've got separate guidelines for chest pain of recent onset. So that's basically the rapid access chest pain clinic. So if the GP or in the community they diagnose what could be angina due to coronary disease, then they should be seen within 2 weeks in the chest pain clinic. And then, as you can see, this is completely out of date. 2010 revised in 2016. And the main take-home message for what happened in 2016 was that instead of the old-fashioned, angina risk factors, you put them on the exercise treadmill, do an ECG, do they get ischemic ECG changes, and then get a registrar or some ACP or a physiologist to supervise the exercise test and work out whether it's ischemic or not. They've started doing a lot more cardiac CT. So you do a CT calcium score, how much calcium is in the coronary arteries. A high calcium score means that maybe you want to investigate further. A low calcium score means low risk, treat medically or reassure. And then with the CT scans, you can add contrast and do an angiogram, and that's getting better and better and better. So when I first started here, we didn't have a cardiac CT service, and then we sort of did, and now you can do a sort of quite a rough, reasonably accurate coronary angiogram, non-invasively with a CT scan with a bit of contrast on a single heartbeat. So even 2 years ago, you have AF and the patient's got tachycardia, that you can't gate and synchronize the heartbeat, the diaphragm moving with the breathing, with the image on the CT scan. So you get lots of artifacts, you sort of get lots of blurring. But now in a single heartbeat, even in AF, you can probably get the anatomy quite nicely. So there's anatomical sort of testing for ischemic heart disease. And what the exercise treadmill test used to do was do a functional test. So do you get ischemic ECG changes and symptoms? Does the blood pressure misbehave? Does the pulse do anything funny? Do you get arrhythmias? And that's what it's replaced. And then nice guidelines for managing stable angina. So again, just as you'd expect, it's just a history examination, rule out the other things, do the risk factors, and then anti-anginal treatment. This will all come later. Again, I won't sort of go and interrogate everyone, but as we all know, we've got the GTN spray for quick relief, so it's nitrates, vasodilating. Then we've got oral nitrates, we've got beta blockers, we've got calcium channel blockers, which will be dihydropyridines that don't slow the heart rate. We've got diltiazem and verapamil that do slow the heart rate, and they'll be anti-angina as well. And then we've got nicorandil, which is no longer first line, it's more third line, don't use it, which is a pretty good drug, potassium channel opener. And if you do find it in some people, then you stop it because it can cause GI upset and bleeding from, sounds like Crohn's disease talking about, from mouth to anus. You can get ulceration and fissuring and bleeding from nicorandil, even though it's a very good drug. And then you just give the drugs of secondary prevention. So that's going to be your aspirin, your statin, your ACE inhibitor if they've got a tight narrowing, or if they've had an MI, so something to lower the risk in the future. And then if things are not satisfactorily controlled, then you can do angiograms, functional testing, and then revascularize by balloon angioplasty, stenting, or bypass surgery. So that's the stable anginas in not very much time at all. And then this just basically summarize what you've sort of seen before, but coronary plaques getting worse layer by layer, and you don't sort of get this overnight. It's a bit like trees growing. You chop down the tree, look at the trunk, you know how many years it's been alive for. Each ring on the tree trunk, sort of cut surface area, will tell you, how long the tree's been alive for. Similarly, if you look at coronary plaque, it sort of builds up bit by bit, just by having very minor acute coronary syndromes, plaque fissure, rupture, a bit of platelet form, maybe a bit of clot, and then the next layer of cholesterol will build up as well. That load of inflammatory stuff that we just heard will sort of build up the next layer of plaque, and then eventually that can narrow the blood vessel, cause impaired flow, impaired perfusion, and then the symptoms and so on and so forth. And the next slide should summarize basically what happens. So you've got in the top left, you've got the coronary anatomy. So you've got two left coronary arteries coming from the left main stem, and you've got one right coronary artery. And if you've got a dominant right coronary artery, which is what 2/3, 3/4 of people have, then it's bigger and it has the posterior descending branch, which, as the name suggests, supplies the posterior wall. And it includes in the name the left anterior descending artery supplies the anterior wall, and it gives you a diagonal branch that supplies it laterally, and the circumflex goes around the heart, supplies the side or the lateral side of the heart, and a bit of the inferior wall. And then you match up with the ECG on top right, so you've got the anterior leads, the septal leads V2 to V3. So all the anterior leads are the V1 to V6, but they lead V2 to V4. Inferior leads are 2, 3, and ABF, as you know. The high lateral leads to the diagonal branch of the LAD, or maybe the circumflex. And then if you've got dominant circumflex, or a very dominant right coronary artery, one of those blocks, then you can get infraposterolateral MIs, can't you? And also, from the ECG tools that you use when you go back to medical school and revising for MRCP to part 1 and all that kind of stuff, and the odd talk, you get in the true posterior infarct, don't you? And that's the posterior descending branch is blocked. And also, the right coronary artery has got a right ventricular branch. So if you block that, then you infarct the right ventricle, and then the right ventricle doesn't work, so you get blood go to the lungs from the heart. And I think when you meet enough cardiologists and ACPs, and you sort of know that we very much dislike people giving lots of fluid for LV dysfunction, MIs that you don't want to cause fluid overload, and even surgical patients on the wards where you do your night shifts and looking after the wards. Apart from in right ventricular infarction, if you infarct the right ventricle, you mess up your preload use of your diffusion of the lungs and the blood going into your left heart. And actually, you do give fluids. And if you don't give fluids, then the patient may die of that, be hypovolemic rather than the other way around, which is what we usually try and avoid. And then you'll see on the bottom left is how much time you block the artery for, and what gets ischemic and what muscle dies, and the time scale for that. And that sort of tells you that maybe if you do a primary PCI, you may consider not doing it if you're beyond 12 hours, simply for thrombolysis. And then on the right hand side, that just shows the sort of circular repetitive way you get plaque rupture, a bit of clot, things organised, you get a bit more of a fibrous cap, a bit more of a tough sort of surface. When it all heals, and you get a bit more plaque. So that's the pathophysiology again. And the ischemic cascade. So this is what you see and what the patient feels. So the heart is functioning normally when nothing happens. Then you get your plaque rupture, clot, and reduced perfusion. And then you notice that the patient will feel something as soon as the muscle doesn't get any blood, and they get ischemic, and they get angina or anginal pains or MI pains. And you'll know that from when you clerk people, A&E, MEAU, or when you're in the ambulance or GP surgery, they don't. Every time I see sudden onset chest pain in the note where there's an end STEMI or a STEMI, that's probably not true. It's not something instantaneous from 0 to 100% in an instant. And that's aortic dissection. That's a ruptured sort of viscera, a ruptured vessel, subretinal hemorrhage, something like that, something very sudden and vascular. But these are more rapid onset. And actually, you'll see that you get echo changes and LV changes before you get ECG changes. And then I had an old boss who did lots of echo, who just sort of said, if somebody comes in with chest pain, yeah, do the ECG, of course, but he'll make me carry as a registrar an echo machine just to look at the LV, just to see if I can find a regional or motion abnormality first. And then we'll say, oh, how clever are we? And we kind of work cleverly, and he's a professor in Australia now. And then you get the pain, and then you get the muscle death. And then that's just more guidelines about risk factor management. This is from an MRI talk, and you can divide the heart into 17 segments in echo and in MRI, or 16 segments. And in myocardial perfusion scanning, the nuclear method where you give the radio trace camera, you find the company that invented that thought, oh, I know, let's make a bigger profit and divide that up to 20 segments. So when I was reporting MPIs this morning, I was using a 20-segment model. Anyway, and you know from echo images that circuits the hearts are supplied by certain coronary arteries, and you sort of call them by all these various names, and you can sort of guess the artery and try and confirm it later when you treat the patient. And then this talk is supposed to encompass stress testing. So you've got, I talked about exercise treadmill testing, not very high specificity and sensitivity. And for example, in a middle-aged woman, aged 50, then you may as well flip a coin. It's 50-50 whether it's positive or not, and you get ECG changes in most of them, and how to interpret is quite difficult. And the SD, depression and elevation, you're supposed to measure 2 little squares after the QRS complex for your sort of most accurate thing. That's what they did all the research. And then you've also got stress MRI. You've got stress echo. So you give them Butamine and C, which was the heart muscle don't work so well, and then you can equate that with an artery, and then you might move to an angiogram. You've got the MPI, which is what I was reporting this morning. So you give you put a drip in, you give a stress agent. So instead of, as well as the Butamine and adenosine, which gives you pharmacological stress to the heart, you can give regadenoson, which is like an adenosine analog that's sort of manufactured. We give that instead, and it affects the lungs a bit less, still slows the heart down a little bit. And we're seeing more people in cardiac MRI using regadenoson as well. And in the cath lab, they can do a pressure wire test, and they can stick a wire down through the narrowing, measure the BP before and after the plaque. And if blood pressure drops with adenosine, then maybe it's a flow limiting lesion. So all these are sort of stress tests. So it kind of makes the learning objective of the talk a bit more complex. There's lots of stress things. And you can imagine that some clever people are trying to do stress perfusion CT scanning as a research tool these days, and that they're not that far off. So, and then on an MRI scan, we used to give thallium, and now we give technetium for nuclear myocardial infusion scans. So you sort of label the blood with thallium technetium, and the gamma camera will just sort of take a photo of where the tracer goes, and if it goes in that part of the heart, then it means the circulation there is okay. You've got good flow, good perfusion. And with MRI scans, you give gadolinium, and that will just go where the blood flows. And then the interesting thing about MRI scans is that this late gadolinium enhancement. So you give the gadolinium, do the MRI scan, wait 10 minutes, and then you get funny patterns. And these are the funny patterns. So with coronary disease, you can get subendocardial infarction. It'll just go sort of bright white on the endocardial surface. So in the top left, and if you've got a transmural full thickness Q wave infarct, then the whole thickness of the LV wall, in that case the septum, is going to turn a light on and look sort of bright white. And in non-coronary disease like sarcoid and all this kind of stuff, you get other changes and other myogonitis. So you sort of can get kind of false positives as well as deliberately trying to look for those non-cardiac, non-coronary things. So this just shows where the gadolinium hangs out after you wait 10-15 minutes and take another picture, and you can see subendocardial, the full thickness. Then on the bottom right, you've got an aneurysm. And the other clue about permanent damage is the muscle is not uniformly thick; it's sort of very thin and doesn't move so well, thinned and akinetic, so not moving. Right, so something a bit more up to date, and I'll just glide through all this because basically you know it all, and you know all the acute coronary stuff pretty much. It's just sort of trying to jog your memories, and then I always look at who authors in case I've worked for any of them or know them. It's not this one, but although Vijay Kanudian is a consultant in Newcastle, and she went to Newcastle as a consultant after I left as an interventional fellow. So as you all know from other guidelines, you got class 1, class 2, class 3, and class 1 is just definitely do it. Class 2, you got 2A, which is should do it. Class 2B, you should consider it. Class 3 is just don't do it at all, and it's based on level evidence and sort of very relatively rich specialty in cardiology. We do lots of research trials, lots of randomized controlled trials, 11 level A, and then B, and then C is just a few people having a chat. So an ACS, as you realise, those nice guidelines for just the spectrum of things, and they've quite nicely sort of decided that ACS stands for something. And so yes, I think invasive management, do you want to put in or stent something or bypass something, then yeah, sadly, a lot of cardiologists have this oculophalangic reflex, see a blockage, stent it, which is probably not necessarily the best thing either. It's not a sort of reflex thing, but it can be quite tempting. And like I said before, yeah, think about the thin blood antiplatelets, and not only have we got the aspirin and the second antiplatelet, agacolor, or clopidogrel, also got a parenterally one called Cangrelor that they're using in some cath labs. We don't really have it yet. That will actually quicker to get into the circulation even faster. And then we've got other things like glycoprotein 2B3 inhibitors. You remember that's a slide of platelets and all the funny receptors. That glycoprotein 2B3 inhibitor is nearly as strong as a thrombolytic. And just have to be careful when you're on the wards. If somebody's had one of those, then they can lose all their blood, bleed, and lose all their platelets within a few hours. And we've got tirofiban, integralin here. The first one of those is called Riopro or Epsiximab. So they just sort of very strong antiplatelets. And then there's a whole load of cardiology is a different language. All these sort of little terms I won't go through. But you can cheat by going through the ESC guidelines, scardio.org, and then you just download this slide set, and lo and behold, just a quick 5-minute look at those before an exam or before you or after you see a patient may be quite helpful. So yeah, you've heard about the high sensitivity troponins already, and I'll blitz through all this because it's all pretty boring. But essentially, yeah, you give your antiplatelets. And then when somebody has a cardiac arrest, always think, just like your sort of your H's and T's when you do your ALS, it could be an MI, couldn't it? And also think about your differential diagnoses of aortic dissection, PE, etc. So all this, I won't go through any of this. So what I'll do is I'll deliberately digress and show you pictures. So this is a case. So not acute. This is has been an acute patient in the past, but 68-year-old female, stable angina, Canadian class 3, and when you it's a bit like NYHA class, so it's symptom class. So class 1 to 4, 4 is the worst. So rest and minimal exertion, you get the symptoms. Class 1, you can do sort of most things and exercise, and then you get the symptoms. And then so she's got pretty severe symptoms, not controlled by drugs. So that's one indication to do an invasive coronary angiogram. Risk factors: cholesterol, blood pressure. Interesting. I had a meningioma resection. Once when I was an SHO, I was just about to thrombolize somebody with ST elevation inferiorly and chest pain, and then somehow we sort of felt slightly different when she got a rash, and that ended up being meningococcal meningitis, causing a type 2 MI. And I think you mentioned in your talk that you've got a different sorts of MI. Type 1 is the coronary plaque event, plaque rupture, blocked artery. Type 2 is another illness causing MI type symptoms and features, including troponin rise, sometimes chest pain. So chest infection can do that. And also when we had COVID, lots of people getting myocarditis as well, which is not quite an MI because you don't damage the heart. But essentially troponin comes from the heart, and the higher troponin is, whatever illness you've got, the worse you do. his prognosis. And luckily, we didn't thrombolize the meningococcal patient, and she generally had SE elevation and chest pain and a rash and a bit of photophobia in the end. So abnormal ECG, some T-wave inversion, exercise treadmill test back when we used to do those. So some non-specific changes, and then she had an angiogram that showed a right coronary artery occlusion, good collateral branches from the other side, from the left coronary artery, that was mildly diseased, and good LV function. So if the LV is good, you've got everything to play for. And similarly, if you've got severe disease and you don't know whether, and you've got poor LV function, if you do an MRI scan and see how viable the heart is, so if you can revascularize, stent, or bypass something and get the circulation going through to that muscle again, and that can revive and make it work again, and it's viable, that's quite handy to know. Anyway, so she's referred for an angiogram, and we've got some moving images, so that will keep us all awake. And it's interesting because with one case you can actually see all the coronary anatomy. So on that left picture you can see we've got two catheters in. So again, you get two for the price of one. So one catheter in the left coronary artery and one in the right coronary artery. And you can see the right coronary artery, the one on the left-hand side, is completely blocked in the proximal section, and bits of it fill, but they fill because they're filling from the collaterals on the left coronary artery, and they're also filling from bridging collaterals on the right-hand side, just going bypassing, like the slip road on the motorway, going up and that little roundabout, and going back down again and filling it up forwards. And then what do we do? So when you do balloon angioplasty, you stick a wire through the blockage, you blow up a balloon, and you squeeze the plaque out of the way, and then you put a stent in. But that wasn't possible, so we quickly abandoned that procedure. So anterograde wiring, so going forwards through the right coronary artery, that didn't work. We abandoned the procedure.
Why it didn't work? Why it didn't work?
Because it's a chronic total occlusion, and when you put it's a bit like if you pull one of your hairs out by mistake and you try and thread that through a brick wall, you can't. It just sort of recoils and you can't get it through anyway. And if you imagine trying to put a metal or some sort of funny alloy wire through a brick wall, it feels like that. You can actually feel it very firm, very hard, and impassable. And then if you're not careful, you can break the artery. You can cause a dissection. That's exactly what we did. And you can see in the bottom left, you can see this contrast that's exited where we put the wire. And if you perforate that and you get bleeding into the pericardial space, you get tamponade, and that's obviously not a good idea. And luckily, so we abandoned the procedure, did an echo, there's no effusion or bleed, and observed and then sent the patient home. But then the medical management still didn't work, so then we brought her back for a more complex PCI. So we did the same thing again, and you can see the artery on the right coronary artery. The right coronary artery looks the same as before, so completely occluded, and the bridging collaterals. And then we thought we'd be clever and do a PCI with a retrograde technique. So this is just to keep you all entertained. So basically we put a wire down through the left coronary artery, through the collaterals, and then decided to stent the right coronary artery backwards. And those septal branches, so you can see on the right hand side, those things going vertically downwards, the septal branches that supply the right coronary artery backwards, and it fills up the right coronary artery. You can actually see the length of the occlusion. and then we sort of fed a wire, loads of fancy balloons and funny equipment, hence all these fancy words that you can ignore those. And then the wire goes through the septal branch. Then I use a balloon to make the septal branch a bit wider without bursting that, breaking that artery. If you perforate the septal branches, then by again, the clue's in the name. It's in the septum. You don't get bleeding into the pericardial space. You do get bleeding into the septum, but that usually is not so harmful. So you don't get tamponade, which is why we do that. If we did it through other collaterals, then you can still get tamponade and intersect. Then we've basically got a massive long wire to go. So you feed the wire through the septal branch into the collaterals, then back to the blockage in the right coronary artery. Then you start ballooning, putting stents in, and then you realise you've got a very long wire, and it goes all the way around the aorta and then back through the groin on the other side. Then you've got to feed it back through the tube. So basically, you've got one operator holding the wire out of the left groin or the left wrist, and the other person holding the wire on the right hand side. And actually, if both operators pull the wire, then you end up like a cheese wire, and you can end up cutting the aortic root and causing a dissection of the aorta. And this was done with my old boss in Nottingham, and they didn't do a lot of these retrograde sort of PCIs in those days. And yeah, so we just end up sort of ballooning and stenting things. I'll just go through these very quickly because it's not going to help you pass your MRCP or become a medical registrar. And funny enough, we did dissect the aortic root. So this introduces to a bit more of the talk that comes a bit later. And yeah, you need a phrase book to translate the angiogram reports when you sort of see them in the notes when you see the patient on call. But and sure enough, it's a bit like doing a science A level at school. Your conclusion that you need more research and more work needs to be done, and every sort of good article will sort of end in those words. And we've got excellent results and loads of stents. You see every angiogram report's got excellent results. And then I had a boss in Nottingham who used to say adequate results. And then you know that was a very difficult procedure. And it was also very modest, so he never took any praise. And the right hand, that's intravascular ultrasound. So you can actually just I'll just skip over that, but you can actually stick an ultrasound probe in the coronary artery and look at where you put the stents and how big the arteries are. And not only do we have an ultrasound, intravascular ultrasound IV US, we've got optical coherence tomography. So a bit like we go to the optician, they look at the back of your retina. You do that with the coronary arteries as well, and you can even resolve down to looking at individual stent struts, and you can measure how big the vessel is and whether you squeeze the stent to the size of the blood vessel. Because if you leave any gaps, they can restenose and block and clot. So here's our excellent results. Right. Then the echo afterwards showed that we didn't cause lots of aortic regurgitation, and the CT scan showed that we didn't cause a massive type A dissection. And then the patient was observed and went home. I'm also going to digress, and we've got. See, I've got the answer in the name now. So, right coronary artery vein graft occlusion. This was an acute patient who had loads of stents previously in the right coronary artery vein graft. And the reason why I'm telling you this is that with bypasses, you use the left internal mammary artery usually, which is underneath the left collarbone, and they'll detach that from the chest wall, and then anastomose that will sew it onto the LAD vessel beyond the blockage. And they can use the right internal mammary artery as well. They can use radial arteries. And also, as you know, they can use vein grafts from the saphenous veins in the legs to do bypasses. And they join from the aorta to beyond the blocked artery. And so this guy, 77, worsening stable angina, comes in acutely, a few risk factors, and previous bypass, and the bypass needed more stenting within the right coronary graft, had 3 stents in there already, and an arteriopathy with peripheral vascular disease, and also polymyalgia rheumatica. So a lot of these people have got alternative vasculitides as well, don't they? And also when you sort of see middle-aged women with acute coronary syndromes, don't forget that they can dissect the coronary arteries, spontaneous coronary artery dissection, SCAD, SCAD, and that's a separate mechanism altogether. So, so whenever you see somebody who's had a bypass before and they need an angiogram, you need to know where they put the bypasses, and then you may need the operation note. Similarly, when you see somebody with a STEMI, and they've got new left bundle branch block, which is a STEMI equivalent, then you hardly ever have their old ECGs, do you? And then do you know whether they need a primary PCI unless they've got it stored somewhere? And as you know, another trick is when you sort of see somebody who's obtunded, unwell, then you've got their summary care records, you've got their bloods, and whatever you can find in your sort of nanoseconds of spare time when you're clerking them. So this is the top is an open graft, it's obtuse marginal product. So you can see the graft starts at the aorta and finishes beyond the blockage in the artery. And then you can see the lower images, the left internal mammary artery. That's not playing. And then we see the right coronary artery completely blocked. And then we use a balloon to dilate what we can. This time we didn't cause a dissection, thankfully. And then we still couldn't get through. And then we used a bit of kit that we don't use nowadays. There's still this one in Nottingham called the angiojet, which is the little thing that makes a bubbly noise, a bit like somebody with a bad abdomen and breaking wind all the time, and sort of gurgling away. And basically, it's called realistic sort of plaque modification, and that can sort of create a channel. And then in the end, we again we filled the right coronary graft with loads of stents.
What's the angiojet?
I'll show you a picture in a sec. Yeah, basically, don't learn this. It reminds me about the other things I need to tell you. That's the angiojet. So basically, it's this little thing that sort of squirts out some fluid at a very high pressure, and it somehow sort of dissipates and gets rid of stuff in the artery. We don't use that anymore, and there's no real evidence for it, but it kind of works. We don't have one of those here, but what we do have here, which is important for the talk, is we have a laser that can disintegrate clot in front of your eyes. It can modify plaque. We've also got the shockwave lithotripsy, so a bit like renal stones, but you can do that with the coronary arteries as well. So we've got that training that will soften plaques, and we've got the rotational atherectomy, which is a bullet-shaped diamond-tipped bit of metal that weighs around 140 to 180,000 revs per minute. Sounds like a dentist drill. It doesn't actually drill, but it does what we call selective cutting, which is not really cutting apparently, but it can basically break down bits of plaque, and it doesn't. All the little fragments don't block the artery and plug the very small side branches or the arterioles, etc., because they're smaller than red cells, the fragments that you make. And then people keep on reminding us learning how to use it. It's not a drill, but it certainly sounds like one, acts like one. You certainly break arteries with it. And if you have a diamond thing that goes about 180 1,000 revs per minute inside your artery, then you've got to be very careful not to break anything. Simply when you use a laser, you don't want to start making holes. And all of these things, when you sort of use them, can cause bradycardia, arrhythmias, and all sorts of things. And whenever you use these bits of kit and angiograms and angioplasties, you need X-ray contrast. And you use too much of that, you get renal failure and contrast nephropathy. So that's a bit more about the mammogram. So I'll just finish that one there. So that's from many moons ago, but then I'll just show you this thing here. There's a trip down memory lane. Yeah, I don't believe we were given this title, which is basically half of cardiology. So imaging in coronary disease. So basically, you've got anatomical imaging, so angiography and CT scanning, and the basic cross-sectional imaging to look at the heart. But they don't actually look at the coronary arteries themselves very accurately until recently with CTs. They're not much better than invasive coronary angiography. And then you've got functional imaging, which is where the sort of stress comes into it, MRIs, stress echo, MPIs, etc. And looking at perfusion. And more pretty pictures. And there's a thing called the biphasic response. So you can imagine if you put anyone's heart and you soak it into butamine, which is an inotrope, you up their blood pressure, up their pulse, you can cause all sorts of mischief, arrhythmias, tachycardia, you massively increase their cardiac output, you strain the heart a lot, and there'll come a point, if they've got lots of disease, if they've got PLV or critical coronary artery disease, that can make things worse. And similarly, if you've got a myocardial diffusion scan, you give regadenoson stress, chemical stress, and basically that kind of dilates all the arterioles and the capillaries within the myocardium, and you force the blood through there, and that can cause stress as well. And so in MPI, you can get what's called transient ischemic dilatation, where the heart actually looks like it's dilating instead of contracting because you get so much stress, and you can do that with butamine with the stress echo. So you can get this sort of bizarre paradoxical response where it's a high risk feature when they actually do the opposite of what you're expecting. So you want it to sort of pump harder and faster, when actually it sort of pumps more weakly and it starts enlarging, looking like it's bigger than you want. Then that's a high risk feature. Similarly with all these stress tests, if you suddenly dump your blood pressure and then drop it by tens and the patient collapses, then that's not a good thing. And that's just showing a perfusion defect on MPI. And this is a sort of old-fashioned sort of way of doing CT coronary arteries, and it's much more flash than that now. You can measure the calcium score like we discussed. Different ways of classifying stuff. And I'll end that one there. What else have I got in my? Yeah, we're supposed to. Again, if they thought we're going to go 3:20, so we're not doing too badly. You're supposed to get a 15-minute break and discuss it, and then go through cases on sort of mixing and matching. So basically, not listen to the syllabus at all. So I hope you don't mind. We're supposed to talk about type acute aortic syndromes, and this is like a sort of one hour thing, and it's a 2-hour thing in itself, and it is important because until a few years ago, a lot of trusts in the country, including our trust, and it's still very common now, we miss type A aortic dissections, and you must recognize that we do a lot of CT aortas and CTPAs because we miss a lot of PEs as well. And thankfully, the difference between a CT aorta and a CTPA is not, it's just a timing and what you're looking at. And you get a free of charge look at the aorta with the CTPA if you're thinking it's PE, and vice versa. So those are two sort of big medico-legal things you don't want to miss as a medical registrar, or as anyone really. And when I was giving cardiology induction for the last 12, 13 years, I was told by somebody in charge of this in the trust, you must talk to all the new doctors about type 8 aortic dissection in induction. I said, well, I can't give a 1 hour talk in a 1 hour talk, as well as talking about fire and all the other bits, and who's your supervisor. But anyway, aortic dissection, just like, you know, you can imagine, spontaneous coronary artery dissection is sort of pretty similar sort of picture. So you just get any artery has got 3 layers, isn't it? It's got adventitia, intima, and media. Media is a bit of muscle. Intima is a little bit of cling film lining on the inside with lots of chemicals and receptors and lots of funny pathways and so on and so forth. And what you don't want is something to cause a split in that intimal lining and then cause bleeding to separate the layers and unzip the artery. And then when that happens, you end up, when it reaches the side branches, you end up knocking off the organ that the side branch supplies. So and actually they had a phase for a few years of getting everyone in ED and acute medicine and medical staff this very talk, which I make no apologies for repeating. So you've got 2 different ways of classifying aortic dissection, and basically we use type A and type B. Type A is basically ascending aorta from the aortic valve to the left subclavian artery. If that bit's dissected, then the take-home message, you need surgery before you die. And if it's type B beyond the left subclavian, then you can generally get away without surgery and treat medically and manage the blood pressure, which you need to do for both type A and type B. So the lower the blood pressure, the better. And we want it as low as possible, but still perfuse all the vital organs. So often people would say, well, just aim for 100, 110, 120 to begin with. As long as you get blood to your brain and your kidneys, etc., then you should be okay. And then, yeah, every hour that you wait, then the mortality goes up by a lot. And they need sort of immediate transfer to cardiothoracic center if you've got a type A dissection. And when we go through the symptoms, type A dissection is instantaneous, maximum intensity pain, you know, within a second. It's like, some people say it's like turning a switch on and off. And that sort of time of onset and duration of onset is very important. So hopefully you won't be saying sudden onset chest pain for an NSTEMI, you say rapid onset. And if it's sort of instantaneous, you know, sudden onset, then you're thinking dissection or something vascular and an emergency. And that sort of shows a bit more of the pathology. And a whole load of risk factors, which you've all heard of. And yeah, never forget Marfan syndrome, the congenital things, the chromosomal things, and never forget that you do VDRL and look for syphilis. And I think one clinician here has diagnosed syphilis from doing that, and then you give penicillin and the patient is cured. Well, of the syphilis anyway, but maybe not of the complications of that. And also with aortic dissection, you've got ripping, tearing, shredding, very severe, all these sort of superlatives and adjectives that patients describe the symptoms, and it radiates straight through to the back. And depending on which side branch you take out, if you take out the carotid with the dissection sort of crossing through there, then you end up with strokes. You end up with not perfusing limbs. You can take out the kidneys if they're not perfused by where the false lumen is. And then they got a whole load of very emotional relatives who are rightly emotional about it, who are bereaved, and podcasts and different websites and this Think Dissection campaign. Always, there's Dr. Andrews when he was younger, when and then you've got other signs, unequal blood pressures, unequal pulses, and don't forget your differential diagnosis, coarctation, you get unequal pulses, radioephemeral delays, but then with dissection, just if you knock off, you supply to one arm, then you're going to feel different blood pressures, aren't you? Get a wide mediastinum on your chest X-ray, and you do a CT scan, of course. So, and then your ECGs can show ischemia or infarction. Then the epidemiology is quite funny because a lot of people do survive type A dissection when it takes out the right coronary artery. But if you take out the left coronary artery, you usually die of it. And very seldom do we see a type A dissection occlude the left coronary artery at the origin and the left main stem. And if you do, they're almost certainly going to die. And I've not seen anyone survive that. Although I think I've heard of somebody recently in the last couple of years survived an operation and found that incidentally. So I don't know how they meant it. I think they were congenitally corrected by some other congenital abnormality or something like that. Anyway, we won't go through all the bloods and things, but as you know, for any medical admission, then it'll be almost a crime not to do an FBC, UNE, ECG, chest X-ray, a glucose, and a urinalysis. You've got to justify how not to do it. And you've got the wide mediastinum on the chest X-ray. And you can sometimes see a dissection flap on the echocardiogram. And they say that doing a TOE is going to be much more sensitive than even a CT scan. But I was once told by one of my bosses, who ended up being Vice President of Education for the British Cardiac Society, that he used to supervise my TOEs. He said, although that's in the textbooks, don't ever do that because you need a whole load of sedation. And if you don't give them enough sedation for a TOE when they're having a type A dissection, their BP will just go up, hit the roof, and then you extend the dissection and they die in front of you, and you get a complication in your logbook, and you get a dead patient to look after, all the sort of patient affairs, and it's not very nice. So although it's more sensitive, it's practically not that possible. And also they get an on-table TOE when they go to the surgical centre to get things prepared. Obviously, if you dissect back towards the heart from your aorta, sorry, this is going automatically. You get pericardial effusion, pericardial bleed, and tamponade, and they can die of that. So type A dissection, immediate surgery when you recognise it, and control the blood pressure while you're waiting, and control it with labetalol or esmolol, which is esmolol is obviously short-acting, and you just give it as an infusion. You can adjust it more easily, but quite expensive and tricky, and it's difficult to know all the doses. Easier in this EPMA age where you can sort of just where you get sort of suggested dosage regimes and things like that. But yeah, so I think aortic dissection. So get rid of that one. I'll just show you some myocardial perfusion imaging. Any questions so far? Any questions online?
Out of curiosity, if can you hear me? Sorry.
1-year-old woman, atypical chest pain, a few risk factors, and comorbidities, referred for nuclear myocardial perfusion scan. Is there reversible ischemia? And yeah, again, as you know, whenever you ask for any test in medicine, you request the test, you ask a question, you know what, and pretty much have an idea of what to do with the answer. And with all these things, and especially with cardiac things, you're not going to do anything unless it helps the patient feel better, improve their quality of life, or improves their prognosis, or prevents sort of bad events. So anyway, so we give regadenoson as a stress agent, and we give technetium labeled. Apologies, let me just. Okay, so when with query angina, risk factors, is there reversible ischemia on a nuclear myocardial perfusion scan? Give regadenoson chemical stress agent, which gets a bit short of breath. A bit like when you give adenosine, they're going to get short of breath and you exacerbate their asthma, and you slow their heart down, you cause heart block if you're not careful. But luckily we don't get that too much with regadenoson. And pulse blood pressure didn't do anything, she was a bit overweight. The ECGs didn't show anything. And you got, this is what the MPI looks like. You get stress images and rest images. And the top two lines are the short axis. So you've got the anterior wall at 12 o'clock, the inferior wall at 6 o'clock, the sector between the LV, which is the round thing, and the RV, which is the thing on the left, which you can't see so much. But the sections on the left-hand side at 9 o'clock. And the lateral wall is from between 12 and 6 o'clock on that sort of circular thing. You've got stress at the top, rest at the bottom, and basically you spot the difference. Yellow is where the blood goes, and purple and pink is where the blood doesn't go. If it's green or black, there's no perfusion at all. And then short axis views at the top, and then you've got the middle two rows are looking at the LV from different projections. So you've got the anterior wall at the top, got the inferior wall at the bottom, you've got the apex where you think the apex is, and you'd be right. And then the bottom images are another view, long axis views. So again, you've got stress and rest, and the apex is at the top left and N shape, and the lateral wall is on the right hand side, the septum is on the left hand side. And then when you starting not to move very well. Then when you summarize that in a different way, so basically you get a sledgehammer and you bash the heart, then you got stress at the top, rest at the bottom, in the middle, and some sort of digital subtraction. Stress minus rest is the difference, the reversibility at the bottom. And you can see that with your eye, you can see a bit more purpley in the anterior wall after stress, and it's a bit better perfused and better uptake, more blood supply in the anterior wall at rest. And so you think there might be about 3 segments of ischemia or reversibility there. So that's a positive result. So, and then we think there may be an intermediate risk of having an MI. So then she gets an angiogram. So misbehaving again. And you can also look at the LV function with an MPI scan. So stress on the left, rest on the right, and what I've done there is I've stopped the cardiac cycle in end systole, so when the heart's contracted. So the green bits are diastole, where it's sort of full of blood about to contract, and the bit into the silver grey in the middle is when the heart's contracted. And you can see that all regions seem to work pretty well and contract. And with ejection fraction. And when I told you about that transient ischemic dilatation, So when we gave that regadenoson, the heart didn't look like it dilated after stress. It was look bigger than at rest to be a high risk feature. This is not moving so quickly. My computer's telling me funny things. I'll get rid of this then. Right. What time is it now? 15:40, so we've got 20 minutes. Any questions?
No.
I'll just get to the I'm gonna stop sharing quickly and then start sharing again. And then we'll glide through the rest of it and then finish. We're pretty much on time. Yeah, so this is just the way the guidelines work. They sort of tell you what's new and what's changed. We'll go through that. We'll just go through the pretty pictures. And that's just reminding you that when you take the history, then not many people will say, I had a chest pain. And it's amazing how much you read in the notes. Oh, this patient has complained of a crushing retrosternal chest pain. How many people have said that? I think I met 2 people who said crushing in the last year. They always say indigestion, heartburn, all these things that are sort of a bit more gastrointestinal, aren't they? And they say, well, it wasn't really a pain.
Heaviness. They will say heaviness also as well.
Yeah, heaviness, tightness,
Tightness.
burning. Yeah, and then and then I heard somebody who's diabetic the other day say, I felt like a toothache. Yeah, and then neck, jaw, all this kind of stuff. And then obviously, if you're diabetic, elderly, you can get no symptoms whatsoever, just collapse and hit the deck. Then I sort of keep saying this in my ward rounds. If you had never had the misfortune to go to my ward rounds with the elderly patients, and a lot of our wards is full of people over the age of 80 now. And one professor of elderly care, whom I sort of worked for when I qualified as my second job, had a mnemonic, RAMPS, RAMPS. So any old person on your ward, then use that mnemonic. So R is reduced bodily reserve, so all their organs don't work as well. A for atypical presentations, they may not get painless MI. M for multiple pathology. And that reminds me of one cardiologist I worked for who taught me how to do stenting. He himself had a stent and he had a gastric ulcer. He said they felt the same. I now know how the patients feel. Can't describe it myself, let alone listen to them. So yeah, so you can mix it all up. But very few of them say actual pain. And in the chest pain clinic, you sort of say, yeah, or even in clinic, you've been to clinic before, and you say, Yeah, tell me about your chest pain. It's not a pain, and they get really upset when you sort of accuse them of having a pain. And then also the associated symptoms, which I won't go through in detail because you know all this. That's just the saying that when you get a STEMI, you're far better off by treating everything at your primary PCI. But then we also know that if it's 3:30 in the morning and you've done 4 already, you're hardly going to be keen to open up everything. And then I remember when I was an interventional fellow at Newcastle, we were doing the PRAMI trial, where if you sort of randomize the patient at the time of their STEMI, and then your heart sort of sinks, or you sort of get a bit more cheerful when you're in a good mood, that the patient's been randomized to revascularize everything, you stent the whole lot, and you're still sort of standing there. And on January the 2nd, 2010, so before I started working here, I did 6 primary PCIs in Newcastle in one morning. And the lab broke down at number 5, mid stent deployment. You had to move the patient to another lab. It's all very interesting. So these are moments in your career that you'll never forget. Right. Right. And then you know about high sensitivity troponin, and I suppose I'm going backwards. The system can't cope with this very big presentation file. I think you've probably heard enough about acute coronary syndromes, and also when patients have got AF, their PEs, and they're on, or they've got thrombophilia or something, and they're on warfarin already, or on a DOAC already. What do you do? A whole load of guidelines on that, and essentially we can replace, in a nutshell, we can replace their aspirin with a DOAC. And then if they've been stented or they've got an acute coronary syndrome, you might want to give them the second antiplatelet for the duration that they deserve it for, which may well be 3 months, 6 months, or a year. And the operator who does the bypass or the PCI should be able to tell you which one it is. And then the only sort of snag there is that there was a trial called the Pegasus study, where if you've got very complex disease or you're a complex patient, diabetic, elderly, left main stem, bifurcation, branches, junctions, bad LV, then maybe you want ticagrelor for another 2 years beyond the 1 year at a lower dose. But then again, you should know that and be told by the right person. Just very quickly, ANOCA and MINOCA, angina with non-obstructive coronary arteries, ANOCA, or MI, myocardial infarction with non-obstructive coronary arteries. So often you do the angiogram and the arteries look normal, or they look nearly normal, and then you just got to be careful it's not a spontaneous coronary artery dissection where you can find this sort of double lumen on the angiogram, or they've got microvascular disease, so there's small vessel arterioles, capillaries, whatever it is, whatever's in the myocardium is not working so well. So same risk factors, microvascular disease. Nowadays we've got the pressure wire that I sort of said right at the beginning, that can measure the blood pressure before and after a blockage. That can also measure the coronary flow reserve, and can measure parameters in indices for microvascular disease. So when you've got this thing called the IMR, or the coronary flow reserve, is abnormal, it might just say you've got microvascular disease. You still treat the same thing, but there's nothing to balloon, nothing to stent, and prognosis is not that bad. And the other sort of non-obstructive thing is you've got patients with ectasias, so big baggy arteries. The blood flow can be a bit slow, You can get sort of little clots in those sometimes. What else can you get? You get a variant in China, prednisone in China, or vasospasm, so the artery can spasm. And in previous guidelines, the ones that I used to grew up with when I was a junior doctor were, you can give ergonovin in the cath lab to stimulate coronary spasm and hopefully not kill the patient, and then you can demonstrate spasm. And then they changed that to you can give acetylcholine, and then they sort of now changed it to you may want to give that if you're desperate, but try not to. And if you've got vasospastic angina, you might want to give something like ranolazine instead, or a calcium channel blocker that can be a bit more antispasmodic. And quite often you get somebody come out of the cath lab, non-obstructive coronary arteries. Could it be a PE? Let's do a CCPA, or get an echo or whatever. I decided to not to show you a whole load of ECGs. The convex ST elevation for STEMI, reciprocal changes in the opposite leads, and ST depression. You've got different types of ST depression as well. So if it's horizontal or planar, then it's likely to be significant in shape. And if it's downsloping, that's worse than upsloping. Upsloping ST depression is a bit less likely to be abnormal. And then also you've got some T wave changes, and Q waves are that initial negative deflection. If it's pathological, then it should be wider than one little square and deeper than a quarter of the R wave that comes after it. So you can see there's a T wave inversion, some upsloping, there's depression. Sort of biphasic ECG T wave changes. It goes up and then it goes down and then back up to baseline. So it feels like a little S shape or biphasic. And if you get that in the anterior leads, anteroseptal leads, Whelan syndrome or LAD syndrome, and the LAD vessel may be the one that's causing the acute coronary syndrome. And then you've got, that didn't mention a new left bundle branch plot, which we kind of mentioned before. That tells you about the antiplatelet stuff. And all this is in the guidelines. I won't sort of dwell on it. And then all the sort of education, rehabilitation stuff is there. And quite often on my ward rounds, I ask the patient, so what have you been told about what's happened? And then not only do you do their mental capacity and start their rehab at that time, you can actually then find out how little they've been told. And even more embarrassing is when you discharge them and they've not even received a single information booklet. So, go through this stuff. So on the chronic coronary syndrome stuff, so stable angina, they make a big thing of estimating the pre-test likelihood of coronary disease. It's a bit like when you do maths and stats and Bayes' theorem. If they're likely to have it beforehand, then you do the test, and that will sort of influence whether you sort of treat or not, and how you work up the patient. So obviously, very young people with accumulated too much, they're not going to be at high risk. But like you said already, that's we still see young people get MIs, and never forget the cocaine and drugs question. We've got a lot of people taking anabolic steroids for their weight training, and we've got people taking cocaine, and that's in some hospitals in America, that's the biggest cause of MI in their emergency rooms. And then just all the usual tests. It's a bit like looking at the contents of a cardiology textbook. Then yes, which drug was invented first. We have a habit of starting sublingual nitrates and maybe an oral nitrate and a beta blocker first, don't we? And and one reason why we're obsessed with in cardiology, having a new score of 0 is probably not enough for a ward round. We want to know the heart rate and the blood pressure, and we want to perfuse the vital organs. And for heart failure and for angina and MIs, we like the heart rates about 60 or a bit below that. And when we used to give thrombolysis and give IV beta blockers, we used to get people's heart rates down to 40 something deliberately with IV atenolol. I never thought I'd be saying that again, but having thrombolized people this week, we might be doing that again, giving IV beta blockers. And nowadays we give IV beta blockers before a coronary CT scan to slow down the hearts of the ECG gating, and the image accuracy is better. And yes, we've all seen platelets with all the different receptors, and where aspirin and the thromboxylator and the PY 12 inhibitors. So we go through that in detail. But when you go to a Royal College of Physicians educators session, and then some people who undergo that course, their sort of biggest nightmare is talking about the Krebs cycle or glycolysis and all those sort of fun, all the coagulation cascade, and teaching that. I'm quite boring. So provocation testing for spasm, I sort of mentioned that already. Healthy lifestyle education. So that's all acute stuff. And how long have we got left now? So 4 minutes. So stable angina, not very interesting here, apart from when I showed you that case from 2009. It's actually what I presented at the British Interventional Society conference, and then Professor Adrian Banning from Oxford was actually moderating my session and was fortunately very lenient on me and didn't have a go at that chronic total occlusion. But the guy from Brompton, the professor, said, "Oh, congratulations on opening up that occlusion. I would have done it very quickly, and I would have gone anterogradely and not retrogradely." To which Prof. Banning said, and then called in and said, "What's your success rate?" Then Scott Brompton said, "Oh, it's about 70%." I said, "But I thought you said 100%." Anyway, so sort of party politics in the conference, and poor little me at the front, surrounded by all these sort of ex-colleagues and old bosses, and so at least I survived that. That's the Canadian class thing. I think that's probably, and we're very good at this hospital for not doing the echocardiograms, aren't we? Because we're short of staff. So whenever they get an MI, they should have an echocardiogram as an inpatient, and if not, we do it as an urgent outpatient for the end STEMIs. But all STEMIs should have an echocardiogram, which then reminds me about focus and feel echoes, and that's becoming more and more trendy. And I actually, even though we're not on the general medical rota as cardiologists anymore, and even though, like when I qualified, when you do a post-take ward round as the medical team, we used to start on CCU, even if you're a gastroenterologist, and then go to ICU, then see the cardiac patients first, then manage all this ACS stuff yourself, and then if you're stuck, then you ask a cardiologist. So a bit weird. So it's all completely different now. And I went to the Royal College of Physicians Med Plus conference just to remind myself of what I've forgotten over the last 15 years, which is basically quite a lot. There's a shame in some ways that we don't sort of converse enough between the specialties these days. So there's lots of new recommendations, but these are just sort of all these sort of questions that that you sort of ask yourself, and we've kind of covered it all already. And I think we'll get some pretty pictures near the end. Or they made a mistake in the thing they forgot to put a slide in. So when you're preparing for a talk, then you sort of decide to get some revenge in some way. Right. Yeah, sadly for cardiologists, we're a greedy bunch and we want to be in charge of everything, including aortic dissection. And and the European Society of Cardiology, they want to do the aortic dissection and peripheral vascular disease and do the jobs of the cardiologists, the vascular surgeons, which is pretty insulting. But the summary of all that is vascular surgeons and stroke people quite like clopidogrel as well. And now the cardiologists are now arguing maybe we should just have used aspirin all along. And the other thing that I haven't mentioned here is that in cardiology you sort of see in other specialties that we're doing cardio-oncology, cardio-rheumatology, yeah, cardio-obstetrics. Yeah, I think there are a few of us who don't want to rule the world and take over. This is the same as before. Right. Well, thank you for your attention, and thanks for putting up with going through most of cardiology as you see it in a couple of hours.
Thank you so much, Abdulrahman.
Any questions?
Minoka and Inoka, both are the same term, like synonym.
Minoka is MI with non-obstructive coronary arteries. Anoka is angina.
Oh, okay.
Yeah, and obviously we see false positive and false negative, functional tests, and the WHO definition of MI is kind of on history, ECGs, and cardiac enzymes, isn't it? And then we've also got that 5, type 1, type 2, type 3, 4, and 5, and obviously one of those types is iatrogenic MI, as well as coronary plaque and the secondary to other illnesses, and mainly chest infections cause it, don't they? And AF can do a bit of a type 2 MI, and never forget that a rate-related angina, a lot of them do have proper coronary artery disease underneath it all, and diabetics don't do so well. So I think that's about it. I don't know if anyone's asked anything online.
No worries. I have some quick questions.
Yeah.
I know that there's no standard recommendation for managing type 2 MI other than treating the underlying. Or in situations where you see that the troponin is raging, it's really quite high, over 1,000 or something like that. I don't know why they've checked it because of some ECG changes.
Yeah.
Do we give them anything at all?
I think we probably follow them up less than we should, but then also we're in danger of over-investigating and over-investing in those people. But if they've got, say, AF rate-related angina or chest infection, they've got definite ECG changes, then maybe some of them should get a coronary CT scan, calcium score, and maybe some of them should get functional testing if it's convincing. But then they have to request it, and then it can get rejected, can't it? Over sort of vetting the referrals, and obviously we can't do a POCUS on everyone. We can't do an echo on everyone either. And forever in our cardiology meetings and governors meetings, we're sort of moaning about people organising inpatient 24-hour ECGs when we've got telemetry. But obviously, when you're on the medical assessment unit or MAU here or wherever and you've got a cardiac monitor on the bedside, you can't record and you can't sort of play back, and you do a POCUS in A&E, then you don't record the images, you just describe them. And we've had, in my last ward week, we had people with not coronary disease, but people with SVTs, arrhythmias, AF, people just took a photo of the monitor, and then you had to go to A&E, get a copy of the photo on a bit of a photocopy of that, and then bring it back to the ward, and then you can't tell whether it's regular, irregular, whether the paper went in correctly or not. It's all very, very strange. So I've seen a lot of people have riddled with disease. I'm treating a patient at the moment who's got atrial flutter, good LV, diabetic, myeloma as well, and she's the one with the teeth pain, and I think it's angina equivalent. But then the CT coronaries that I ordered has not been done yet, and the cardioversion that I requested has not been done yet either. But her LV is good, her left atrium is not enlarged, and she's diabetic, so I reckon, with comorbidities as well, so I reckon she might have quite severe coronary disease causing her teeth pain. Then we're really closing, we sort of say, oh, get them onto our own angiogram list, or I'm not going to go into my NPI list. I'll just sort of treat it like we normally treat people. Right, interesting. It was good to dress up, not in scrubs, and wear a shirt and a proper jacket for a change. I nearly put a tie on today, and then okay, well, thank you for your
Thank you so much, Dr. Van. Thank you, Abdulrahman.
Picture of yourself.
Yeah, thanks for your bit. You sort of glued all my